Hi, this is Dr. A with a Clean Chem review video on thyroid disorders. So let's start with hypothyroidism. It is defined as a low free T4 level with a normal or a high TSH. It is one of the most common disorders of the thyroid gland. It occurs in 5 to 15% of women greater than 65 years old, and it actually just generally occurs in about 5% of women. It's quite common. It can lead to hyponatremia or low sodium levels, anemia, and hyperlipidemias. And it can be divided into primary, secondary, or tertiary disease. Again, primary means the thyroid is messed up, the thyroid gland. Secondary is the pituitary, and tertiary is the hypothalamus. So it just depends on the level of the dysfunction. The most common cause in developed countries is what they call chronic lymphocytic thyroiditis, which is also known as Hashimoto's thyroiditis. Individuals should be tested beginning at the age of 35 and every 5 years thereafter, especially women, and more frequently if risk factors are present. Hashimoto's is treated with thyroid hormone replacement therapy, but I do want y'all to note that there are some lifestyle changes that can also be effective in treating autoimmune thyroid disorders, although they don't really replace the hormone replacement therapy. And I showed this little kitty cat all sleeping and all that because with hypothyroidism, you are really, really tired. So what are the signs and symptoms of hypothyroidism? It's all due to a slowing of metabolic function. So you will see weight gain, dry skin, constipation, cold intolerance, puffy skin, hair loss, fatigue, and menstrual irregularity in women. Severe untreated hypothyroidism is called myxedema and can lead to heart failure, seizures, and coma. In children, hypothyroidism can stunt growth and delay sexual development, and in infants it can cause mental retardation. So that would be a symptom, but also like a cause too. So what are the guidelines for screening for hypothyroidism? Again, at the age of 35 and probably every 5 years after the age of 35. Most doctors, if you're at least 35 and over, will check your TSH at least yearly. Individuals with risk factors or symptoms, so if they have a goiter, presence of other autoimmune disease, a first-degree relative with an autoimmune thyroid disease, use of lithium, which is used for bipolar disorders, and amiodarone use. These guidelines are from the American Thyroid Association and the American Association of Clinical Endocrinologists. THYROTOXICOSIS is a constellation of findings that result when peripheral tissues are presented with and respond to an excess of thyroid hormones, too much thyroid hormone. Possible causes could be you're taking too much thyroid hormone, maybe the drug dosage is too high. Leakage of the stored thyroid hormone from the thyroid follicles where it is stored. And maybe then excessive thyroid gland production of the thyroid hormones in the case of hyperthyroidism, and we're going to look specifically at Graves' disease. The symptoms are anxiety, emotional lability, so meaning that like really mood swings and kind of flying off the handle. Weakness, tremor, palpitations, heat intolerance, perspiration, and weight loss. So a lot of these are like opposites of hypothyroidism. And so TAS is kind of a good representation. It's kind of like anxiety, but they also like can't sleep, really active and stuff, and yeah, with the heart racing and stuff like that. So Graves' disease is the most common cause of thyrotoxicosis or too much thyroid hormone levels. So Don Knotts here is a pretty typical poster child of Graves' disease. It is an autoimmune disease in which antibodies are produced that activate TSH receptors, so that causes then the thyroid gland to produce too much thyroid hormones. The features is thyrotoxicosis, so high levels of thyroid hormones, so T3 and T4 with very low to undetectable TSH. Goiter, so a swelling in the throat, you can kind of see it a little bit here, and an ophthalmopathy, we're going to look at it, but the bulging eyes is part of it, and also there are some dermopathies there. There is a strong familial disposition to getting this. 15% of the patients have a close relative with this condition. Women are 5 times more likely than men to develop it. And lab testing will show high free T4 and or free T3 levels with undetectable TSH. The symptoms of the ophthalmopathy are orbital soft tissue swelling, injunction of conjunctivae, proptosis, double vision, and corneal disease. They tend to have like bulging eyes, is also called exophthalmos, is definitely one of the prominent signs of Graves' disease. The treatments for medications are given beta blockers, propylthiouracil and methimazole. They can be given radioactive iodine, which destroys the thyroid tissue to make the patient hypothyroid. And then, of course, so basically they kill the thyroid and then start giving synthetic thyroid, doing thyroid replacement therapy since they killed the thyroid, right? Or surgery. It is preferred in cases of thyroid cancer or to avoid the eye problems that are associated with a radioactive iodine treatment. Then we also have a toxic adenoma and multinodular goiter. And this is caused by autonomously functioning thyroid tissue. It is neither TSH nor TSH receptor stimulating. Immunoglobulin is required to stimulate the thyroid hormone production, so it's totally independent of those. It's associated with some receptor mutations and some toxic nodules. It occurs in patients with hyperthyroidism and palpable nodules. And so this is what a goiter looks like. I'll put it up there with a kid. In children, goiters are usually due to like vitamin A deficiencies. So I just wanted you all to see what a goiter looks like. And the treatment is usually surgery, radioactive iodine treatment, or medication. There's also drug-induced thyroid dysfunction. The most common one is amiodarone-induced thyroid disease. Amiodarone is a medication that is used to treat cardiac arrhythmias. It is spot-soluble with a long half-life of about 50 days. 30% of its molecular weight is iodine, and so the effects of that is it inhibits thyroid hormone production. It's called the Wolff-Chaikoff effect, and it blocks the conversion of T4 to T3, which again, T3 is the active form of the hormone, and therefore it leads to hypothyroidism in 8 to 20% of the patients, and can lead to hyperthyroidism in 3% of patients. Then you have subacute thyroiditis. It's characterized by transient changes in thyroid hormone levels. So the transient is something that comes and goes. It's associated with inflammation of the thyroid gland, leakage of stored thyroid hormones, and repair of the gland. I found that it was often associated with viral infections. There are 3 classifications of subacute thyroiditis. It could be postpartum, so then that would be post given birth. That occurs in 3 to 16% of women that are postpartum. It can be painless, so it's similar to the postpartum type, but it's not associated with pregnancy. And it can be painful, and the painful classification is characterized by neck pain, low-grade fever, myalgia, tender diffuse goiter, and swings in thyroid function tests. So it can go from hypo to hyperthyroid. There's also non-thyroidal illness. So those are abnormalities in thyroid function tests of hospitalized patients, especially in critically ill patients. They are characterized by a low total T3, free T4, and TSH. So it's central hypothyroidism. Less T4 is converted to the active T3. It leads to decreased levels of T3 and higher levels of reverse T3. So again, probably because of high cortisol because of stress. Why stress? Because of critically ill. So again, this central hypothyroidism, and then of course the thyroid hormone binding changes. That protein is probably due when the patient is critically ill, production of albumin and the thyroid hormone binding globulin decreases, and so these changes are associated with severe illness. You have less protein to vary the hormones, and you will have lower levels of the hormones of the T4 and all of that. So all these changes could be simply appropriate adaptations to illness. So it could be simply a slowing of the metabolism of the body, so that energy can be diverted to the immune system to fight whatever illness is going on, or to simply the critical areas. So again, if you want to know true assessment of thyroid function in your patient, you want to do this when they're not ill. And then we have thyroid nodules. There are clinically apparent nodules that are present in 6.4% of adult women and 1.5% of men. So they're like, feel like little balls or little nodules in your thyroid. The thyroid ultrasound can find unsuspected nodules in 20 to 45% of women and 17 to 25% of men if you do an ultrasound. And despite the frequency of thyroid nodules, only 5 to 9% of these non-palpable nodules prove to be thyroid cancer. Finally, the fine needle aspiration biopsy with cytologic examination of the aspirate is used to determine the need for surgical removal and to determine if it is thyroid cancer. And that is the end of it. Thank you.